So now time has come to now start a morning seminar from Igenomix. Good morning, ladies and gentlemen. Today from Valencia, Spain, we invited Dr. Carmen. Carmen先
生はIgenomix
Dr. Carmen is a scientific director, leading scientific director in Valencia, Spain, especially around the PGT-A in non-invasive development. She has been putting focus on over the past 3 years, and big progress has been observed in the past 3 years. So she would like to share with you the 3 years her effort.
Thank you very much, and thank you to all of you to come today to listen my experience working with the non-invasive approach for aneuploidy testing of the embryo. This is my very first time in Japan giving a talk related to our work, so I'm really very happy and very pleased, and I wish you enjoy the talk. First, I would like to start explaining the importance of aneuploidy in the human embryos. We know because we have analyzed thousands of trophoectoderm biopsies. This is our experience with the analysis of 133,000 biopsies in which we have done the test at the very beginning on day 3 embryos and in blastocysts. And we know that the incidence of aneuploidy in IVF patients that are of advanced female age or they have recurrent miscarriage or repetitive implantation failure, under particular conditions, we know that the incidence of aneuploidy in the human embryos can be really high. If we are thinking in blastocysts, in more or less half of the blastocysts on day 5, they can have a chromosomal abnormality. And if we are working with day 3 embryos, the percentage of chromosomal abnormalities is even higher. There is a moment in which some abnormalities result in embryo arrest. So when we have embryos with a particular type of abnormalities that are the chaotic embryos, these ones in the orange line, the chaotic embryos, they are pretty frequent, it's the yellow line. They are pretty frequent on day 3. In about 15% of the biopsies of day 3 embryos, we can observe chaotic embryos. We define chaotic embryos as those embryos that have 6 or more chromosomes that are abnormal. So when we have so many abnormal chromosomes, this really impact embryo development, and these embryos arrest. And that's why when we are analyzing blastocysts on day 5, day 6, or day 7, the incidence of chaotic embryos should be very low, below 2%, because these chaotic embryos usually arrest before morula stage. They don't reach blastocyst stage. So this is an example of one type of chromosomal abnormality that produce arrest of the embryos and they don't reach blastocyst stage. But these are usually mitotic events. But for most of the cases, when we have just one single aneuploidy, for example, a trisomy 21, or when we have from 3 to 5 aneuploidies, we can see that the incidence of aneuploidy is constant. So we really have incidence of aneuploidies at different stages of embryo development. And for the really risky aneuploidies, at the single aneuploidies that can result in a live birth, there is no selection during embryo development. So there is no self-correction for this single aneuploidy. There is kind of self-correction only for the embryos that are grossly abnormal, that have many, many aneuploidies. And these are the really risky cases. So this establishes the basis why aneuploidies can be important for reproduction. And we have been developing different strategies to analyze the chromosome content of the embryos during many years. Preimplantation genetic testing for chromosomes started close to 30 years ago, And at the very beginning, we didn't have very good technology. I started to do this on 1993, and at the very beginning, we were able to do only day 3 biopsies. We didn't have lasers in our laboratories. We were using thyroid acid, and we were making a hole in the zona. We were retrieving one cell, and we were using fluorescent in situ hybridization. And with this technology, we were able to analyze a limited number of chromosomes. At the very beginning, only 3 chromosomes. Later on, we have more and more fluorescent proofs, and we were able to analyze 5, 7, up to 12 chromosomes. But it has a limitation, and it's the nucleus. We have one single nucleus, and we have to hybridize with the DNA proofs, and there is a spatial limitation to analyze many, many chromosomes. So this technology worked for some of us, but also there was a high controversy related to the benefits of this technology at this time, because to perform the day 3 biopsy, you have to be very careful not to damage the embryo, and you can perform the day 3 biopsy only in embryos with more than 6 cells, so you need to be very conservative not to damage the embryo. So this technology was working more or less up to 2010, and around 2010, the molecular technologies that were applied to blood or to other kind of tissues was improved, and we were able to apply molecular technologies to the small amount of DNA that we have in a single cell or in few cells from the trophectoden biopsies. And this was a big change, because we were able to analyze not only one cell, we were able to analyze 4, 6, 7 cells from trophectoden biopsies. The laser started to be very common, so with laser you can do trophectoden biopsy really in a fast way and without damaging the embryos. And then we were able to apply first array CGH or other technologies such as SNP arrays or qPCR, and we were amplifying the DNA. We were not analyzing chromosomes independently, as in the fish. We were melting the DNA, we were doing amplification of the DNA to have multiple copies of this DNA, and then we were applying these technologies. And arrays were very successful for more than 5 years, but starting in 2013, 2015, next generation sequencing technologies appeared in our field, and then we were able to apply this technology. The most important platforms that appear at this period of time were the platforms from Illumina and from Thermo Fisher. Both platforms really work it nicely. You need to understand the protocol you are working with. You need to understand the technology. And what is really very important is not the technical protocol in the lab. You need to perform this following strictly the protocol, but it's very important the bioinformatic analysis of the sequence. So this is what makes the differences among different labs, because you need to understand how amplification protocols work in the DNA, and you need to understand what is really normal and what is really abnormal and what is a mosaic and what is not a mosaic. So the importance of next generation sequencing technologies is to work with bioinformaticians and to develop a proper algorithm to diagnose properly the embryos and to say what is normal and what is abnormal very accurately. So at the very beginning, we were using next generation sequencing with the commercial platforms, but in the last years, we have developed our own algorithms, and we have learned which cases there are real abnormalities and which cases are noise, because we know that depending on the quality of the DNA and depending on the amount of DNA, in some cases we have artifacts, and it's very important to recognize artifacts, because we don't want to release a report saying that one embryo is abnormal if it is not truly abnormal. So this is the improvements that we have been performed in our PGT-A protocols in the last 2 years, working at the bioinformatic level. So now we have the next generation sequencing technology with us. we have the possibility of doing trophectoden biopsies, and there has been some studies publishing good results, other studies that were saying that maybe the results are not so successful. I can tell you that we feel very happy with the results in trophectoden biopsies when you are doing properly the trophectoden biopsy and when you are applying properly the technology, not to overdiagnose aneuploidies. But even though we know that trophectoden biopsy is an invasive technique, and this is the technology that we have been applying so far all around the world. I think in most countries in which the biopsy is being accepted by the scientific societies, the most common strategy is trophectoden biopsy now. People is not doing day 3 biopsy anymore. Only in few countries in which they cannot vitrify the embryos. Is in, for example, Emirates. They cannot vitrify the embryos. They have to do day 3 biopsies to have the results for a fresh transfer. But this is the most common strategy. You remove from 5 to 8 trophectoden cells, you place in a PCR tube, and then you have the NGS results. Here you have an example of a monosomy 16. This is a female embryo. This because the comparison is with a female DNA. This is 2X, and then we have a monosomy 16. And what is coming now is the non-invasive approach. And we call this a non-invasive approach for embryo grading. It's going to be a way of identifying the embryos. And now what we can do is to culture the embryos, as usual, in the IVF lab, and then when we are removing the blastocyst to vitrify the blastocyst, we can take the media that in regular conditions is going to be discarded. Instead of discarding this media, we can place the media in the PCR tube, and we can apply next generation sequencing protocols to this media. Because we know that the embryos are releasing DNA to this media when they are growing. It's similar to the non-invasive prenatal testing, that we know there are cell-free DNA from the fetus circulating in the maternal blood. So this could be something similar. It's cell-free DNA from the embryo that is floating in the media. And it's more or less a similar approach to prenatal, in which we are now implementing the non-invasive approaches. So this will be the translation of the non-invasive approaches from prenatal to pre-implantation development. And by applying the same technology, next generation sequencing, these are results from the same embryo, biopsy and culture media drop, the results are very similar. We can observe also the monosomy for the chromosome 16. And there are important questions. This is really new for all of us. We didn't expect to observe cell-free DNA from the embryos in the culture media. We don't really understand why the embryos are releasing this extra DNA. And the questions are, is there embryonic cell-free DNA detectable in the sperm culture media? If there is DNA, if detectable with the technologies we have. And the second question is, does this DNA represent the chromosome content of the embryo? So these are two big questions that we wanted to solve. So there is a very nice review by Hammond and colleagues in which they explain the possible sources of DNA that we can find in the IVF media when we are doing an IVF cycle. If we are growing embryos on day 3, we know that we can have attached sperm, we can have cumulus cells, we can have the DNA from polar bodies when they start degradation. We can have extracellular vesicles because there is trafficking throughout the zona pellucida, and particularly on day 3, when there is fragmentation of the embryos, we can have apoptosis necrosis. So we should take care about the cumulus cells because they are female XX and they can really amplify. We should take care about polar bodies. We don't know about the amount of DNA, or if there is DNA in these extracellular vesicles, we don't know, but maybe there is DNA inside. We should take care a lot about culture media contamination. So during IVF procedure, we are manipulating the embryos, we are doing dishes with the culture media. We have to be very careful not to contaminate the drop, the dishes, the pipettes with DNA. So these are all the potential sources of DNA on day 3. And at blastocyst stage, we are not so worried about apoptosis necrosis due to fragmentation. We are not worried really about the sperm because the sperm is not amplifying. In the protocols we are using for NGS, the sperm is not amplifying, but we are really worried about the cumulus cells and about the culture media contamination. So in the next slide, I'm going to present our experience in the last years in which we have learned what we can get from the culture media and how we can improve the protocols to make it really a clinical test. So we started with this more than 4 years ago, and our first publication was in human reproduction, and it was a proof of concept because, as I mentioned before, we were very skeptical. We didn't understand why the embryo wants to release DNA to the media. So we were really very skeptical, and we started with this study really to test if there was DNA or not in the media. And later on, this year in September, we published in Fertility Sterility the improvements that we have performed in the protocol and the results that we had. So let's start by the first publication that was the proof of concept. And in this publication, we were comparing the results of media in contact with the embryo compared to control drop media that has never been in touch with the embryo. So we observe higher concentration of DNA in the sperm culture media than in the controls, making us think that the DNA was secreted by the embryo because we observe higher concentrations before amplification and after amplification in both circumstances. Also, it has been described that in the mouse embryo, there can be self-correction of aneuploidy, and that the aneuploid cells can start apoptosis and the DNA degraded and maybe expelled to the media. And we were not very happy with the idea that human embryos undergo apoptosis as a tool for self-correction, because we know that in humans, the incidence of aneuploidy is much higher than in mouse. We know that in humans, if we have a miscarriage, more than 50% of the miscarriages are because of a chromosomal abnormality. So we know that chromosomal abnormalities do not disappear in humans in the same way as mouse. So we were comparing the amount of DNA in euploid normal embryos and in aneuploid embryos. And we observed that euploid embryos release the same amount of DNA that aneuploid embryos. So this is not because the aneuploid embryos self-correct and release abnormal DNA. The euploid embryos also release DNA. What is the conclusion of this? That this should be a physiological mechanism of healthy embryos. It's not only for abnormal embryos. It should be a physiological mechanism of the embryos when they are replicating the DNA in the different embryo divisions. And we wanted to check also if males and females released the same amount of DNA, and it was just the same. So this study of quantification of DNA was performed in 53 medias and 17 medias, and in the other half of the embryos of the study, we were comparing the results of the trophectoden biopsies and the media. And in this study, we were using embryoscope. And embryoscope, you know that you need about 25 microliters of media. And in this study, we were collecting the media always on day 5. So we were changing the media on day 3, and we were collecting the media always at a fixed point that it was day 5. And we were not cleaning the embryos especially. We were just doing our regular ICSI without cleaning the embryos especially, without paying attention to that. Also in this study, we were doing hatching on day 3 because we did this for blastocyst biopsy on day 5. So the embryos has been previously manipulated. The embryos had a hole in the zona pellucida from day 3 to day 5, and the embryos were not especially clean to remove the granulosa cells. So in this study, the concordance rate was only 30%. So we were really disappointed. We say, okay, it's only 30%. If we can have only 30% of the media with similar results than the trophectoden biopsy, this is not going to be effective for clinical application because is very low concordance. And we observe very high contamination with cells from the mother. That means from the granulosa cumulus cells. In some cases, it was full maternal contamination, giving us a result of normal XX. And in the other cases, it was partial maternal contamination, giving us like kind of intermediate profiles. Also, we have close to 9% of cases in which we didn't have information because there was not enough amount of DNA. So after this study, we were thinking to stop the research. That's the truth, saying this is no way to continue with the research. But Carlos Simon was pushing us to try to continue with this because there is something there that we don't understand. But if it is happening during pregnancy and the placenta, should happen in the embryo also at the beginning. And also we had several publications in the last years achieving different results. In all these publications, the embryos had been previously manipulated in some way. They were doing assisted hatching in most of the studies, or they were doing biopsy previously to the collection of the media, or vitrification was also incorporated previously to the collection of the media. And also in 2 studies, the culture media was combined with the fluid of the blastocellular cavity. So it was like blastocyst collapse or aspiration of the media from the blastocell cavity. So the results in some studies were very good, 85.7, 87.5, very good results, very high concordance rate. If we can achieve this concordance rate without manipulating the embryos at all, then we will have a non-invasive approach. But these studies were not really non-invasive. These studies were minimally invasive because they were doing assisted hatching and vitrification. They were not removing cells, but they were manipulating in some way the embryos. So what we really wanted is just to achieve these results, but without touching the embryos at all before blastocyst stage and before media collection. And this is what we did in our second study. But I also want to point out another important thing in this slide. In some studies, they compare the results of the trophectoden biopsy with the media, but also of the media with the full blastocyst. And surprisingly, they observe better concordance rate when they compare the media with the blastocyst than when they compare the biopsy with the blastocyst. And you have 3 examples here. In this study, the concordance rate of the media with the trophectoden biopsy was 82%, but the concordance rate of the media with the whole blastocyst was 93.8%. So maybe the media is getting DNA from the full blastocyst and not only from an area of the blastocyst. And these 2 other studies had very similar results. The concordance rate with the trophectoden biopsy was 87%, and with the full blastocyst, 96 or 96.8. So there are now 3 studies saying that maybe the media is more representative than the trophectoden biopsy related to the whole chromosomal status of the embryo. So just taking all these studies into consideration, we were running our study, as I mentioned, completely non-invasive. And the only thing that was very important for us for the very beginning is to eliminate very well the cumulus cells or granulosa cells that surround the oocytes. You can do this with IVF or with ICSI. You don't need to do ICSI for this approach. The important thing is to decumulate very well the oocytes or the zygotes before fertilization or after fertilization, just to remove the cells. And you can grow the embryos in your regular conditions in the IVF lab up to day 4. And on day 4 is when everything starts to be very important. Probably the release of DNA from the embryo starts to be very active at this point because of the number of cells and because of the mitotic events that started to be much more frequent at this stage. So on day 4, early in the morning, or very late on day 3, we suggest to do special washings, to wash individually each embryo in a series of drops to eliminate the DNA and the contamination from the previous days, and then to transfer the embryo after the washings to a small drop, 10 microliter drop. So a smaller volume allow us to concentrate the DNA released by the media. So 10 to 15 microliter drops works very nicely. And the embryos are not affected by the medium. We realize that they are growing very nicely, they reach blastocyst stage, and they implant in the same way that if they are in drops of 30, 40 microliters. So this volume is a good volume. We can get good DNA, and the embryos are growing happily in the drops. So we performed this study in collaboration with Genera, the clinic in Italy of Professor Ubaldi and Laura Rienzi. And the embryos were grown up to day 5 or to day 6. Some of them have been growing up to day 7. And they grow until the day they consider it was the optimal day for the biopsy. We didn't fix a day. If the embryos were fast, they were growing up to day 5 to do the biopsy. If they were a little slow, they grow up to day 6. So we had the possibility of comparing the results of day 5 and day 6 to see which is the best moment to collect the media. And then they were doing the biopsies, but the way in which they were doing the biopsies in this clinic, they were not performing the whole in the zona pellucida. They were not doing assisted hatching on day 3 or before the biopsy. They place the embryo to do the biopsy, and they make the hole at the same moment of the biopsy. So the embryos were not manipulated before that moment. So when they place the embryos in the biopsy dish, we collect the media, and we place the media in the tube. We were analyzing the media blindly. So they were doing the biopsy, they were having the results of the trophectomy biopsy, and they were transferring the embryos according to the trophectomy biopsy. In our lab in Igenomix, we were receiving the media and we were analyzing the samples, but we were not sharing the results to them. So they were transferred the embryos according to the trophectomy biopsy, but we have the controls. This was the IVF lab part, and now I'm going to talk about what we did in the molecular laboratory, what we improved compared to our first study. So we realized that the amount and the nature of the DNA in the media was different than from the trophectomy biopsy. So we worked in the amplification protocol, in the whole genome amplification protocol, and we modify in a way that we can increase the DNA. So in this electrophoresis gel, you can see the results of the conventional protocol that we use for trophectomy biopsies. We cannot see a clear band or a really faint band. Only after long time in culture you can start to see DNA. But with the modified protocol that we have now incorporated, we can see DNA in most of the cases. So this really makes a difference for us, improving the molecular protocol. And it's also very important to understand that the DNA from the media is different than from the trophectomy biopsy. Therefore, the algorithms for diagnosis should be adapted to this DNA. We are not using the same algorithm that we are using for the trophectomy biopsy. We have developed a completely different pipeline for diagnosis, targeting this special DNA. And I think this also makes the difference with the previous publication. Bioinformatics now are very, very important in our field. So these are the results of this pilot study that I mentioned we published in September this year. At the end, we had 108 blastocysts with results informative in the trophectoderm and in the media. So the informativity rate, when we were collecting the media on day 5, only 24 hours in culture from day 4 to day 5, informativity rate was 81%, not very good. But if we culture the embryos 2 days, then informativity rate was close to 100%. So to have the embryos one more day in culture improved the informativity rate a lot. Also concordance rate. If we collect the media on day 5, the concordance rate was 63%. That it was better than in our first study. That was only 30%. So we doubled the results in our first study. In our first study, we were collecting also media on day 5. So by improving IVF conditions and the molecular protocol, we doubled the concordance rate. It was okay, but still not good enough. However, if we collect the media on day 6, concordance rate was 84%. And this is very close to the previous publications in which they were manipulating the embryos in some way. So we demonstrate here that without touching the embryos, just by cleaning properly and culturing in a small drop, taking care of external contamination from the technologies in the lab, trying to cover the cap with masks, with gloves, trying to work in good conditions in the IVF lab, we can decrease contamination and we can have this good concordance rate. And this is concordance rate with the trophectoden biopsy. We don't know the concordance rate with the inner cell mass or the full blastocyst. We are doing these studies now that in about 4 months, we will have some preliminary data. We are now doing the inner cell mass biopsies of the aneuploid embryos. So maybe when we compare with the inner cell mass, the concordance rate can be higher as in the previous publications, but we still don't know. These are the results related to the false negative and false positive rate. We had 2.5% of false negative rate and 8.5% of false positive rate. And one important thing for the false positive rate is that in some cases, it was because many chromosomes were abnormal. It was a very noisy profile that now we call non-informative. But you will see some slides with some examples. So we know that we can improve these results. We know that the false negative rate is risky, but is 2.5 and is acceptable. We know that when we are doing trophectoden biopsy, that we say that the accuracy of the test is about 97–98%. So we are close to the accuracy of the trophectoden biopsy. But also, we are comparing everything with the trophectoden biopsy. So maybe if we compare with the whole embryo or with the inner cell mass, these results are much better. So there are still some question marks there. And in the next slide, I'm going to show you some examples of what we see in the lab and what we have learned during these years. So this first example, you have on top the NGS profile of a trophectoden biopsy, and at the bottom, the result of the embryonic cell-free DNA in the sperm blastocyst media. So this is the representation of the sequencing data per chromosome, chromosome 1, 2, 3, so on. And these are the sex chromosomes. This is XY because there is one X and one Y. And these are concordant results. Both the trophectoden biopsy and the media are concordant. This is an example of concordance, but both cases are aneuploid. This is easy. Then we have a curious example. And this is a case in which the trophectoden biopsy has a gain for chromosome 16. This is plus 16 at trisomy 16. And the cell-free DNA has a loss for chromosome 16. And also the gender is different. The trophectoden biopsy is male, and the cell-free DNA is female. So we were discussing a lot with Professor Handisai, and it's really suggesting, this result suggests that this DNA comes from the polar body, because the polar body should have complementary aneuploidies, and the polar body should be also a female because it's from the mother. So this phenomena appear when we collect the media on day 5. So that means that maybe the DNA from the polar body is starting the generation, but still it reacts to the amplification protocol. But if we collect the media on day 6, this DNA is completely degraded and eliminated, and we are not having this kind of issue. So this is one example why collecting the media on day 6 could be more reliable. Also, we have cases in which we have a clear abnormality in the trophectoden biopsy and a completely different abnormality in the media. So both cases, the result is abnormal, but we have different chromosomes. So the explanation could be mosaicism, that we have cells with different chromosome constitution. And we call this partial concordance, because the result as an embryo is abnormal, but the chromosomes are not exactly the same. And sometimes we observe this profile, very noisy profile. It's difficult to say which chromosome is abnormal. And this kind of noisy profiles, we have learned that this is a result of the quality of the DNA, that if the DNA is really very degraded, and this can happen in few embryos, then it's not very reliable. you can think that this is different results, but we really think this is degraded DNA. And when we observe these profiles, we consider the embryo now as non-informative. And the last two examples are the discordance, the really discordance results. This is the scenario in which we have different gender. The trophectoren biopsy is male, and the media is female. So it looks like it's maternal contamination from the granulosa or the cumulus cells. It could be also contamination by a female embryologist, but it's difficult because it's female-female. In this case, we have the trophectoren biopsy that is female, but the media is male. In this case, it's clear that it's because there is a male embryologist that has been preparing the culture dishes or transferring the embryos from one dish to the other. So it's very important to work in a kind of sterile conditions in the lab with these cases to avoid contamination from the skin cells, from the saliva cells, and touching the tips with the surfaces. We just need to work in kind of sterile conditions to try to avoid contamination from the surrounding DNA. The DNA from the granulosa and cumulus cells is a risk, but the DNA that is surrounding the culture conditions from the embryologists, the surfaces, is also very important. So understanding this and paying attention to these potential sources of contamination, we can really improve the results very much. And these are when the cases of potential false negative and false positive. In this slide, you have a very clear abnormality in the trophectoren biopsy, but the media is completely normal and is female. Both cases are female. So false negative are mainly within due to contamination. That means that we can really decrease the false negative if we are very strict when we work in the IVF lab. So it's something that we can overcome. And this is the second case in which the trophectoren biopsy is normal, is male, and the media is abnormal, and a very clear abnormality. And then we start to think, where is this abnormality coming from? The granulosa cells, the cumulus cells are normal. This cannot be contamination from the mother. And the embryologists, they should have normal karyotype. They are not going to have a monosomy for chromosome 10. And the abnormality is so clear that we don't think it's an artifact of the technology. We really think this is real. Could be mosaicism, could be mosaicism. And maybe when we are analyzing the media, we are getting the results of more cells and we are getting more information. And this idea has been supported by our preliminary clinical data that you are going to see in the next slide. In the same publication, we had preliminary experience with 29 single embryo transfers. And it was deferred embryo transfer, as I mentioned before. And embryos were transferred according to the results of the TE, of the trophectoren biopsy, because in the IVF center, they didn't know the results of the media when they were doing the procedure. But when we finished the study, we were putting together the data of the IVF center and the data of the media. And we have 17 cases in which the trophectoren biopsy and the sperm blastocyst media was euploid, was normal. In these cases, the clinical outcome was very, very good. The positive pregnancy rate, 64.7, clinical pregnancy rate, 52.9, and the very important thing, no miscarriage. So we think that miscarriage is what we can really decrease when we analyze the media. So in these cases in which the media was also normal, miscarriage rate was 0, and the ongoing implantation rate was 52.9%. And I have to say that most of these patients were patients of advanced maternal age, because in this clinic in Italy, they were doing PGT-A mainly because of advanced female age. So the average age was 38 years of age. So they were not young patients. However, in 12 cases, they have aneuploidy media. And in these cases, pregnancy rates were lower. And the very important thing, they have 50% miscarriages. So even though the trophectoren biopsy was euploid, they still have 50% miscarriages. And the ongoing implantation rates, you can see how it was 3 times lower than with the media. So this is very preliminary. This is few number of cases. But we were considering this together with these publications in which the result of the media was more concordant with the whole blastocyst than the trophectoderm biopsy. And we are starting to think that maybe the media is more representative than the biopsy, and maybe can really help to improve clinical outcomes in IVF, originally by decreasing miscarriage rate. That is very important. So these were our basic studies, and we want to understand more about the origin of this DNA. First, if this DNA came mostly from the inner cell mass or the trophectoderm cells, and also we want to understand the mechanisms. We don't know if the mechanisms of DNA replication are different at the embryo level than at the somatic levels. Maybe during embryonic replication, there are small fragments of DNA that are released. We don't know. We are working also in collaboration with the lab of Professor Nicolas Placha, because he has described tubulin bridges between cells that they do not disappear after mitosis. And in these bridges allow to communicate cells between them, and maybe there are this communication also externally. So we want to understand if there is DNA circulating between cells and also being liberated to the external layers of the embryos. And we are working with live imaging, staining the DNA with different fluorochromes to try to understand the dynamics of the DNA during embryo development in humans. It's difficult to find a good model for this, because when you use staining for the DNA, usually the embryos are rest in their development. It's not easy to have a good model, but we are getting some improvements on this. We will try to have some nice images for next year. And at the clinical level, we have done the study with a single IVF center. We need to replicate the results in different IVF centers to see if this is consistent and if this can be applied for clinical purposes. So for this, we are conducting a multi-center study in which we were doing the same study, comparing the results of the trophectoderm biopsy with the results of the media. In this study, we are also doing inner cell mass biopsy in some centers, because this multi-center study, you will see, is being performed in different countries. In some of them, research with embryos is allowed. In other centers, in other countries, no. Also, in this study, we want to analyze many variables. How culture conditions or embryo quality affect the results, also stimulation, also sperm quality. So we are going to analyze in total more than 3,000 samples. And we really want to put all the parameters, all the variables in the equation to understand which can be the conditions that can explain maybe the liberation of the DNA, or in which cases, in which conditions we can obtain the best results. And finally, this study is performed in patients that are undergoing PGT-A, because we need to compare the results of the trophectoderm biopsy with the media. But we wanted to see if this approach can be a general approach for every IVF patient, if we can analyze the media to improve clinical outcomes for every kind of patients. More or less the same approach that time-lapse or embryoscope that you apply to every patient to see if you can increase implantation rate, using this as an additional selection tool. So we have the result of the media, we have a grading of the embryos, and you put together the results of the media and the morphology to decide which embryo to transfer first. And the idea is to think in a prioritization system. It's not like the PGT-A that we are discarding embryos. This is just an additional information from the embryo to help to choose the best embryo for the first transfer. And this is the design of the multi-center concordance study. The idea is just to have concordance rate between trophectoderm biopsy and sperm blastocyst media in more than 80% of the cases. Based in our previous experience, you can see there are countries all around the world working in this study. And at this moment, we have already collected more than 1,300 samples, and we are doing the interim analysis at this moment. We are doing the monitoring of the cases in the IVF labs to check for the quality of the data recorded. We are also doing the follow-up of the pregnancies. We are going to test the cases in which there is a miscarriage to do a chromosomal analysis of the miscarriage, and we are going to follow the patients until delivery. So this is an ongoing study, but now we have the possibility to see the results of the first more than 1,000 samples, and hopefully we will publish this interim analysis at the beginning of the year. And the other study, the randomized study, our hypothesis is if we can improve live birth rates by 10% just by adding the analysis of the media to our regular selection tools in the IVF lab. So we are going to have a study group in which we are going to collect the media, but we are going to keep the results blind. So the transfer is going to be performed according to morphology or according to embryoscope. And, this is the control group. And in the study group, we are going to have the results of the media plus the results of the morphology or the time lapse. And we are going to check how the results are different. And we are going to transfer the embryos in the study group according to a classification that we can do with the knowledge we have gained with the 1,000 embryos analyzed. For example, this is just an example. We know that in the media, if we observe an abnormality for only one chromosome, then the results are 100% concordant with the trophectoderm. If we have two chromosomes, they are 85% concordant. If we have many chromosomes abnormal, the concordance rate decreases. So these kind of things, the number of chromosomes abnormal, which chromosome is affected, if it is the full chromosome or a segment of a chromosome, this is going to give us a gradation of the aneuploidy risk for each embryo. Based on bioinformatic analysis of these 1,000 samples, we are going to classify the embryos in 3 categories: green, orange, or red. For the green, they are the safest one, the one that they have the highest probability of being euploid. According to our preliminary data, this is going to be very high, more than 90% when we classify the embryo as green. Then we are going to have an intermediate category that is orange. That is when the embryos have between 3 to 5 chromosome abnormals. We know that in some cases these are false positive. So this is going to be an intermediate risk of aneuploidy, something between 25–50% of aneuploidy risk. So this is the second. If you have embryos in the 3 categories, for sure you will choose first the green, second the orange, or maybe you can decide not to transfer, but we consider that in the prioritization system, this is to be considered for transfer in second place. The very risky ones will be the red ones, in which, in our previous experience, only 5% of them has been euploid. Most of them are abnormal. But also, if you feel uncomfortable discarding embryos, you can just do the genetic counseling with the couple, saying these embryos has lower risk of implanting, they have higher risk of miscarriage. So if you transfer embryos in this category, maybe it's a good advice to recommend non-invasive prenatal testing, for example. So you have the embryo, it's a nice blastocyst, but you have the embryo classified in this category. You can transfer the embryo, but you should advise to do non-invasive preimplantation testing because this is a higher risk of aneuploidy. And we have a 4th category of embryos that are going to be non-informative. That should be less than 5% of the embryos. So the non-informative embryos, in these cases, you should choose according to morphology. You cannot have the information of the embryo. And in these non-informative embryos, the risk is the regular one in the general population. In general, 50% of the blastocysts are euploid and 50% are aneuploid. This is general information. So these cases is like no having information and just based in the morphology. So hopefully, if you apply this system, we are going to have green, at least one green embryo to be transferred for the first single embryo transfer. So the first single embryo transfer can have the highest probability of resulting in a pregnancy and in a healthy pregnancy, in a pregnancy without miscarriage. So this is our vision of how the field of embryo selection is going to change in the next years. And there are several more studies confirming that maybe the analysis of the media is helpful to improve the clinical outcomes. So the conclusions of this talk is that cell-free DNA can be amplified and analyzed by NGS as a non-invasive approach for embryo selection, that the concordance rate between the trophectoderm biopsies and the culture media can be as high as 84–85% if we collect the media on day 6 or day 5.5, is a range between day 5.5 and day 6. That in several studies, the concordance rate of the cell-free DNA of the embryos with the whole blastocyst is even bigger than from trophectoderm biopsies. That this non-invasive approach will allow us to analyze for aneuploidy without manipulating the embryos, and this prioritization strategy will avoid the conflict of discarding potentially euploid embryos. It's just a classification of the embryos. So I would like to thank all of you for your attention, and I would like to say thank you to Dr. Carlos Simon, because he is really the promoter of this study. To my nice team working in the lab and diagnosis is Carmen Garcia, Luis Navarro, and Lucia. Our collaborator in basic research study, Nicolás Placha, and the team of clinical studies that they are doing really a hard work getting the IRB approvals in the ethical committee, and they are monitoring all the data in the different IVF sites. And of course, I would like to thank all of our colleagues in Igenomix in the different labs all around the world. And thank you very much for your time and your attention.
Thank you very much, Dr. Carmen. Thank you very much for your informative lecture. And I think NIPGT is very promising in near future. So you kindly left us 10 minutes for question and discussion. Do you accept some questions?
Oh, sure.
Okay. 今日は通訳の方もいらっしゃいますので、どうぞ日本語でも英語でも結構だと思います。
I am very impressed by your latest information, especially the concordance of the spent media superior to trophectoderm biopsy, right? So my question is, you need assisted hatching or not? Recent publication mentioned that assisted hatching is not needed or is not recommendable due to the laser damage. How do you think?
Our approach is without assisted hatching. I agree, without touching the embryo at all. So just growing the embryo in the IVF lab and collecting the media without assisted hatching.
Okay, thank you.
Any other question? 他にありますか? Okay, so the concordance rate of NIPGT and trophectoderm biopsy is almost 100% when the embryo has only one chromosome aneuploidy, you said. And still, you said we can transfer the red criteria embryos, 1 or 2 chromosome aneuploidy embryos. But when we transfer the 1 chromosome aneuploid embryos, so if the concordance rate is 100%, it means that we transferred aneuploid embryos. Is it okay?
Okay, this is going to be the big question. And this is the results we have with the analysis of 100 embryos. We want to see what are the results once we analyze 1,000 embryos to establish different categories. And I think there are going to be different options depending on the patient, the clinician, the infertility background. I can imagine a patient of advanced maternal age that this is the only embryo that they have. It's the same thing that with mosaicism. Maybe you take the risk. because it's the only embryo and you are not going to do other IVF. If you have several embryos, for sure you are not going to transfer this, and you can always do the biopsy on these embryos. There is a rescue possibility, and for some countries that they are very familiar with the biopsy and with the trophectoderm biopsy, for sure some of them will choose for these embryos to do the trophectoderm biopsy. So I think there are going to be different options depending on the patient, the doctor, and also of the country.
Okay, thank you. どうでしょうか。他にご質問ないでしょうか。
Are there any questions?
どうぞ。
I just I want to ask you, how can you distinguish mosaicism
Okay.
by this procedures?
Okay, this is very good question. We were thinking a lot about mosaicism and the analysis of the media. And we were checking the results considering 30%, 40%, 50% mosaicism level. And there is a recent paper by Catherine Rakowski also working with this, and I'm glad that we reached the same conclusions. If you consider mosaicism at the low levels, the concordance results are very low. She was considering up over 50%, 60% to diagnose a media as abnormal. And we reached the same conclusions like 1.5 years ago. We decided to consider a media abnormal when we observe more than 50% of abnormality. When you are looking at the sequencing profiles, is the copy number variation is giving us more or less than 0.5. Because if we were considering lower levels, I think it's artifactual because the amplification that we are performing. And I'm happy to see that Catherine Rakowski achieved very similar results. So we are not reporting mosaicism in the media. We are just classifying the embryos as normal and abnormal, and not just normal, abnormal. We are going to give the classification in this grading system, green, orange, or red. No mosaicism considered in there. Also because when you have a small amount of contamination from external DNA, the profile can look like a mosaicism, and it's not a real mosaicism. So it's not going to be really accurate if we want to say this is a real mosaic or not. So we have been working at the bioinformatical level, comparing the results at different levels, and the best thing is just establishing the threshold in 50%.
Okay, thank you very much. And I need to ask you another question. And do you have any, the data that you have, some difference among the, embryos structural grade? For example, apoptotic cell must be a little bit higher rate rather than the good embryos. That's why if you are compared those two groups in terms of the embryonic development.
Okay, we have done the study of embryo quality comparing with the results of concordance, and with the first 100 embryos, we didn't observe any relation with embryo quality. At that point in this study, our colleagues in Italy, they were also recording if they were cells extruded that were not compacting and forming the blastocyst. So you have also external cells in the perivitelline space. And also in this first study, we were measuring the thickness or the zona pellucida and of the perivitelline space. We didn't find anything related to the aneuploidy or the concordance. We need to analyze the data with a higher number of embryos for sure, but we don't think that apoptosis is going to be the main mechanism. We don't know the mechanism, and I think it's not going to be an only one mechanism, because in biology, usually there is not a unique explanation for everything. So I think it's going to be the combination of several mechanisms, but I think that apoptosis is not going to be the main contributor. This is our idea so far. We have checked embryos with higher fragmentation, with lower fragmentation, and no relationship.
Thank you very much. I just expected to your, the future development. Thank you.
Thank you.
他にご質問ございますでしょうか。
Any questions?
The concordance rate of day 5 spent media is lower than day 6 spent media. So should we culture the blastocysts until day 6? So I'm afraid on day 6, blastocysts hatched, sometimes hatched. And on day 5, some good quality blastocysts start to hatching. So to manipulate the day 6 blastocysts is somewhat difficult.
Yeah, this is something we have been dealing with, and we have been talking with many IVF centers. Now we are working with more than 25 centers all around the world with these studies, and we have very nice feedback from them. So we know that some people feel complicated just to grow if you have a nice blastocyst on day 5, to keep up to day 6. Our experience with most of the lab is that you don't have really, if you don't do the assisted hatching on day 3, if you don't touch the embryos, usually on day 6, you have early hatching blastocysts, but not completely hatched blastocysts. In our first study, we only have 3 out of more than 100 that they were early blastocysts, early hatching blastocysts. The other ones, they were cavitated or expanded, but they were nice quality. But even though we are proposing maybe a strategy to have not day 6 embryos, but to have day 5.5 embryos. So if you are worried of waiting one more day in culture for the embryos, you can try to do these oocyte retrievals, this pickup, to schedule the latest one in the day, and to do the ICSIs or the IVF cycles the latest of the day, maybe in the afternoon. So if you do this, the last ICSIs of the days, the last IVF inseminations, then if you collect the media early on day 6, the age of the embryos is only day 5.5. It's not exactly day 6. And for many laboratories we have been working with, this is being helpful because they have good blastocysts, but they are not hatched, that for some labs, this is considered risky for vitrification. Other labs feel very comfortable vitrifying hatched blastocysts, but I can understand that for many labs, this is not the best solution. So our suggestion from the feedback we get from the IVF center is to try to delay the pickups and to delay the ICSIs, and on day 6 to try to do the vitrification like the first procedure in the morning. It's also nice because of the conditions, because if you do the vitrification and the media collection the first thing in the morning, you avoid DNA contamination from the other procedures that you are going to do during the day. So just to clean the surfaces, to do the collection, and then to start with your regular IVF routine.
Thank you. 他によろしい。ちょうど時間になりましたが、Dr. Carmen,
That time.
all over the way from the Valencia, and gave us a lecture. Thank you very much. じゃあこれでIgenomixのモーニングセミナーを終わらせて。
This is the end of morning seminar from Igenomix. Thank you very much for attending the lecture session.